Management of Endometrial Hyperplasia, Royal College Green Top Guideline number 67. Part 3. Management of Atypical Hyperplasia. Initial management. Women with atypical hyperplasia should undergo a total hysterectomy because of the risk of underlying malignancy up to 43% or progression to cancer. Looking at the algorithm of the Green Top Guideline for management of atypical hyperplasia here, we see that the first step is total hysterectomy. So total hysterectomy can be performed through a laparoscopic approach or an abdominal approach. The laparoscopic approach carries advantages of quicker recovery, shorter hospital stay, and less post-operative pain. Due to the risks of disseminating malignancy, morcellation of the uterus should be avoided. Also, supracervical hysterectomy should not be performed. There is no benefit from intraoperative frozen section or routine lymphadenectomy. Although endometrial cancer reported in 43% of cases, the cancer was usually early stage with low risk of lymphovascular disease. Regarding ovaries removal, if the patient is postmenopausal, then the recommended is doing bilateral salpingo-oophorectomy with the total hysterectomy. If the patient is premenopausal, then the decision is individualized, and bilateral salpingectomy may reduce the risk of future ovarian malignancy. Endometrial ablation is not recommended because there is complete and persistent endometrial destruction cannot be ensured, and intrauterine adhesion formation may preclude future endometrial histological surveillance. Preserving fertility or patients not suitable for surgery. Considering ovarian conservation, there are several factors. First is age, second is menopausal status, the third is patient preference. Women wishing to retain their fertility should be counseled about the risks of underlying malignancy and subsequent progression to endometrial cancer. So the risks include coexistent or progression to endometrial cancer, coexistent ovarian cancer, metastatic disease, or death. Pre-treatment investigations aim to rule out invasive endometrial cancer or coexisting ovarian cancer. Histology, images, and tumor markers should be reviewed in a multidisciplinary meeting, and the plan for management and ongoing endometrial surveillance should be formulated. First-line treatment with the levonorgestrel intrauterine system should be recommended, with oral progestogens as a second best alternative. Once fertility is no longer required, hysterectomy should be offered in view of the high-risk disease relapse. So returning again to the algorithm, this is the part where fertility required or surgery contraindicated. We see that we're pushing the intrauterine system as a first line and oral progestogens as. So in summary, fertility sparing management of atypical hyperplasia is possible, with 1/4 of women achieving a live birth, but the evidence is weak. It's essential that the initial diagnosis is confirmed on formal hysteroscopy to minimize the chance of missing cancer. The optimal treatment regimen is also ill-defined, and length of follow-up after fertility sparing treatment was short, so risk of relapse in the longer arm is uncertain. Careful counseling about the risks of fertility-sparing treatment is of paramount importance, together with pre-treatment workup to rule out advanced endometrial or ovarian cancer. Because of the rarity and complexity of the clinical scenario, gynecologists should seek gynecologic oncology multidisciplinary advice, where the available histology, imaging, and tumor markers are examined. Follow-up. Routine endometrial surveillance should include endometrial biopsy. Review schedules should be individualized and be responsive to changes in a woman's clinical condition. Obesity is associated with a high risk of failure to regress, and relapse should be taken into consideration. Review intervals should be every 3 months until 2 consecutive negative biopsies are obtained. Again, looking at the algorithm, we see here endometrial biopsy to be taken at 3 months for atypical hyperplasia. In asymptomatic women with a uterus and evidence of regression, based upon a minimum of 2 consecutive negative endometrial biopsies, long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until a hysterectomy is performed. So if we look again at the algorithm, we'll see it here. More than 2 consecutive negative endometrial biopsies at 3 months intervals, thereafter 6 to 12 monthly endometrial biopsy and review. Follow-up should include detailed history, pelvic examination, and endometrial biopsy. If the biopsy is non-satisfactory or the sample is non-diagnostic, then hysteroscopy should be performed. Failure of atypical endometrial hyperplasia to regress is a worrying sign of an underlying endometrial cancer. If fertility-sparing therapy fails to induce regression of atypical hyperplasia by 12 months, or there is evidence of progression to cancer, women should be strongly recommended to undergo hysterectomy. As we can see here in this algorithm, as we said, the indications for hysterectomy would be from the start atypical hyperplasia, or there is evidence of progression to atypical hyperplasia, or there is persistence of atypical hyperplasia, or there is no regression, or there is high risk of relapse. Thank you for your attention.